All right, good morning, everybody. Welcome to Grand Rounds. Thanks, everybody who's here in the room with us, and those of you who are with us on WebEx. We appreciate all of you. Just as a reminder, keep yourself muted, and if you have a question or comment, you can type it in the chat, and I'll share your question at the end of the presentation. And I have the pleasure of introducing today Dr. Gary Walko, who's a professor of anesthesiology and pain medicine at the University of Washington School of Medicine and the director of pain medicine at Seattle Children's. He has conducted multiple studies on pain treatment and assessment in children. Dr. Walko was the founder of the American Pain Society's first special interest group focusing on pain in infants, children, and adolescents, and was the 2003 recipient of the Jeffrey Lawson Award for Advocacy in Children's Pain Relief, as well as the 2019 Distinguished Service Award. He was elected president of the American Pain Society in 2018, is a past president of the Special Interest Group on Pain in Childhood of the International Association for the Study of Pain. Dr. Walko is a founding member and currently on the board of directors for Childkind International. He's consulted on analgesic trials for children and served on the FDA's Analgesic and Anesthetic Drug Products Advisory Committee. He will introduce our other speaker, but for now, I will say welcome, Dr. Walko. Thank you so much.
Thank you. Thank you. Once a year, we have the privilege of offering the Dan and Mary Tarcea lecture that focuses on pain medicine. And you probably are not aware of this, but September is Pain Awareness Month internationally. So we chose to try to pull it off this month. So I just want to spend a moment talking to you about Dan and Mary Tarcea, just so that you may know who they are. They immigrated to the United States from Romania when they were children. They met in Seattle. Dan Tarcea was a Boeing electrician and Mary was a hairdresser. They did not have a lot of money, but they gave of themselves. They gave to the community. And Children's Hospital and Regional Medical Center, as it was then known, was a favorite of theirs. Their daughter is Constance Tarcea Eddy, and she and her husband endowed this fund. They continue to support the fund, and they labeled the goals of the fund to enhance clinical care and education of children with pain and symptoms and their families. The second is to support research to improve the treatment of children with pain and symptoms and enhance their quality of life. So it's always good to just pause and acknowledge the people who make things like this happen for us so that we can continue to learn together. Having said that, in the past, what I've usually done is I've brought in internationally known speakers to come in and talk about their research or some aspect of pediatric pain. This year is going to be different. This one is going to be very local, as you will hear. And when I say very local, I mean you local. So we are going to talk a bit about the culture of pain here at Seattle Children's. I chaired the Pain Champion Committee a few years ago, QISC. Put pain back up as one of the major areas of focus as we began to discuss projects with the Pain Champion Committee. This one was originally called the Go Big or Go Home Project. And we named it that because we decided that literally what we want to do is change the culture of pain here. So with that, our first speaker is going to be Anjali, who will join us remotely. She is a parent of one of our patients and has agreed to share some of her experiences so that we could understand the world from the other side of the bed. Timothy McLaughlin, who's an organization development consultant here at Seattle Children's, will do the majority of the talking. Timothy is here. He has 15 years of experience in delivering large-scale change management and business transformation. I've looked over the list of where he's been and some of the endeavors in healthcare and utilities, telecommunications, the pharmaceutical industry, and the federal government. Most recently, he was a manager for organization effectiveness for Wipro. Did I get that right? And similar roles at Cisco, Northrop Grumman, AstraZeneca, MedImmune, and the State Department of the United States. So by way of background, Timothy has a BS in social science from the University of Maryland, and then did some independent study at Princeton focused on plasma physics. Now, I assume all of you, just like me, immediately got the connection between plasma physics and culture change management, but we'll leave that one alone. Timothy also received a certification in organization development at the NTL Institute of Applied Behavioral Science and change management certification from ProSci. So I'm going to stop talking now and ask Anjali to share her views, and then I will rejoin you.
Thank you, Gary. Good morning, everyone. Again, my name is Anjali, and I want to put in a little plug that this is also National Sickle Cell Awareness Month. So we are celebrating that as well. What has brought my family to Seattle Children's for the past 13 years is my son, Nehemiah, who is a sickle cell warrior. And unfortunately, he has had many hospitalizations and has had to come to Seattle Children's under less than ideal circumstances. Pain is a big component of sickle cell disease, so it's something that we have experience with on virtually a daily basis in some capacity. So I just wanted to speak about our personal experiences at Seattle Children. We have had both positive and negative experiences. Unfortunately, I would say the bulk of our experiences have been less than ideal. And but the good news is there has been improvement in our experiences. So I'm very hopeful and grateful for that. So Nehemiah has been treated for both chronic and acute pain at Seattle Children's. The more chronic pain has been sickle cell related, and we've seen disparities between the management of his pain when it's more chronic or sickle related versus acute after a procedure or a surgery or something like that. It seems that our experience has been that when he's been seen for more acute reasons, the care seems to be more compassionate, and there seems to be more of a robust response to managing pain. However, we have had experiences where when he comes in with sickle pain, where the response has been delayed or has not been adequate for the amount of pain that he is in. And what I want to share is that when we come into Seattle Children's for pain, we have often been trying to manage it at home for several days, sometimes weeks. And managing it at home is round the clock. So it's, whatever the protocol is for his medication, we are like on it, and then also, having to do massage or other, try to utilize other tools. And because Nehemiah has had to go to Seattle Children's so much, we're getting to a time in his life where it's like he is more avoidant or less apt to coming in, or I should say less willing to come in. And so there's a lot of work and a lot of time and exhaustion. When we come in, it's like we have thrown everything we can at it, and we need more help. And so we've come in to Seattle Children's at a point of desperation, and it's like we want to see our child feeling better. It is awful, it is painful, it is gut-wrenching to see your child in pain, and then you feel like there's nothing you can do. You've tried doing everything and it's not working. And so we've had experiences where we come in and it's the waiting game, or we've experienced where he doesn't outwardly present that he is in the amount of pain that requires a prompt response. And as a parent, it's very challenging to advocate when you're exhausted. It's challenging to advocate effectively when you're exhausted, your child's exhausted, you're in pain. And then when you have two parents involved, I can tell you that often they're not communicating well because they're both exhausted and they're both worried and concerned. So it makes for a less than pleasant or positive experience when you come into the emergency room and you're trying to get your child help, and then there's delays, or maybe there's a sense of like you're not being taken seriously. We had an experience where we had a staff member mention to us that it's not life-threatening and that they need to triage more important or life-threatening situations. And even if that's true, that is not something that a parent should or wants to hear, because we're here for our child. And when your child is in that much pain, and again has been experiencing this kind of pain for an extended period of time, you want hope and you want solutions. So, it grieves me to share that we've had these experiences more often than we would care to. And so I just really want to express that it's so important and vital for families to feel like their children are being prioritized and that their pain is being taken seriously. Pain is just awful to have to manage and to navigate, and I think especially for a child. Let's see here. I took down a couple of notes just to make sure that I cover everything. And then, so I think the other important aspect to cover is that parents know their children. And something that we've encountered is that as a parent, and particularly as a parent of a child with sickle cell, I know my child, I know his pain threshold, he knows his pain threshold, and it's very challenging to have to advocate for that or argue that, no, my child, if I'm telling you, or if my child is telling you that what they're receiving isn't working, then I would just encourage you to not just be dismissive of that, because again, people present differently with different types of pain, and in our situation with my child, he deals with it so much that he knows how to be, I think, more, or to present more stoic, or he's mentally trying to be on top of it, so he might not be writhing, he might not be screaming, but that doesn't mean that he's not experiencing a level 10 pain. So I would say just paying attention and listening when a child or a parent is speaking to you about it, and not being dismissive because it's not what you're accustomed to or what you think a child should look like or say when they're in that kind of pain. Also, I want to speak as a person of color that coming into the world in the realm of healthcare is already a very daunting and scary experience, because one, just in general, in the world, there's a lot of adversity and disparity that we're experiencing. And then coming into healthcare, it's hard to, I think, sometimes speak up or feel like we have the empowerment to be able to speak up, because we have had, we being my family, particularly my son's father and even our older sons, where coming into Seattle Children's, we've had experiences where they're not allowed onto the floor, or they have to argue or provide proof or different things to just prove that they belong there. And so when you go through all of that and then your child is unwell, it just adds to like trauma. And so I would say being trauma informed would be very, very beneficial when it comes to dealing with families and pain, because I guarantee you that there are a lot of children and families who have experienced trauma surrounding pain and receiving pain care, particularly when the pain has been chronic. And then I would say that the last thing I wanted to just share is another experience that I've noticed with my child particularly is because he deals with such chronic pain and such a high level of pain, that we've noticed that when his pain is not sickle cell related, sometimes he has a greater response to what we would consider common pain. And I think it's because he knows and recognizes sickle cell pain. And so if he comes in with like a sprained ankle or again, surgery, it seems like he has like, the threshold doesn't seem as high. And so we've had experiences where when he's come in for surgery or something that would be considered minor, where it's like, well, but he deals with, they've even articulated to Nehemiah, well, Nehemiah, you deal with sickle cell pain all the time. This should be easy. This should be, you only need Tylenol, or you don't need, and so it's treated differently than maybe they would treat another patient, because they would assume that this patient, doesn't have much experience with pain. And that's very discouraging. It's quite frankly insulting, and it's just difficult to witness. And then again, it puts the parent in a position to have to advocate again. But I don't want to leave it with all, doom and gloom. We have had positive experiences. I know with sickle cell particularly, there was work and effort put in to change the pathways when it comes to managing sickle cell pain, And I do want to share that we have seen like a 360 degree response to pain since the pathways have been in place. And we've had much more positive experiences as of recent. And so when you listen to those who are providing input and you take it seriously, it makes a huge difference. And the gratitude is immeasurable when a parent or whomever is contributing feels heard and sees the changes. And it just makes for a more positive and harmonious experience in the light of something that is challenging and difficult. So thank you so much for allowing me to be able to share and giving me this platform to speak on behalf of my family and my warrior, Nehemiah.
So I wish I could say that the story you just heard is anomalous, but it is not. I can tell you, as the person who gets the e-feedbacks, as the person who interacts with families in the pain medicine clinic, the story you just heard is unfortunately too common, to which I simply say we can and must do better. So what we're going to get into now is some discussion about exactly what that might look like in this environment. Neither Timothy nor I have any significant disclosures on this topic, but here's something that I want you to ponder for a moment. We are all compassionate people. We went into pediatrics because we care about children and we care about their well-being. We also all took a vow that said, first, do no harm. Yet, in this environment, we have become immune to situations where unambiguously a child is suffering and we keep walking. How did that happen? Why did that happen? How do we change it? I think if we pause and look at our culture, I think we could all agree that preventing and treating pain is a humane thing to do. If you ask parents, and there are data to support this, the second most important issue for parents in a children's hospital is addressing their children's pain. The first one, of course, is please accurately diagnose and treat my child's condition. It is one of the most major drivers of families' satisfaction or dissatisfaction with our performance. If a child's pain is treated poorly and that child is suffering, it really doesn't matter what else goes on. People are not going to view us in a very positive light. And as you heard from Anjali, and you will hear more, clearly there are disparities in the assessment and treatment of pain. There were data published from our organization that showed that if English is not your primary language, the assessment and treatment of that child's pain is going to be significantly less. So I put up the issue of do no harm for a reason, and that is not treating pain well is harmful. We have increasing and overwhelming data to show that as nervous systems develop, if they are being insulted with pain, that development is different. And it's different in such a way that that child is going to become prone to be sensitized to pain potentially for the rest of their lives. So if you don't adequately treat pain, besides what's happening in the moment, you are impacting development as well as setting up emotional trauma, as you heard just now from one of our parents. We know that children are undertreated for pain everywhere. That's both compared to adults. If you look at the exact same surgical procedures and what's done for children versus adults, children are on the short end. And we also are becoming increasingly aware that dealing with people who are suffering in this environment, in any healthcare environment, is adding to job dissatisfaction and burnout. People do not like coming into work and dealing with those kinds of situations. So we formed a group of parents who were my advisory group, and this is what they told us when we asked them about changing the culture of pain here. The first thing they said is make it a priority. Talk about it first. I want my child to be comfortable. If you walk in and start talking to me about a whole bunch of other stuff and you ignore the fact that my child is suffering, I'm not happy. To the point that they see intense pain as a medical emergency. They want a swift response. So just like you see somebody who has extremely high blood pressure or who's tachycardic or who has something else going on, they want that same kind of response. And when they said minutes, their goal was 10 minutes. So if your child is in the hospital, high intensity pain, you ring the call button, you want a significant response within 10 minutes. When you enter this environment and your child is being treated and pain is not being addressed adequately, you lose trust. You say, what is going on here? Why are people not addressing what is clearly such an important issue? And the parents made it clear in our discussions that that lack of trust reverberates. It doesn't just stay focused on pain. They become distrusting of many other aspects of their care. Parents feel that everybody in this organization should be committed to addressing pain. You heard that I am on the board of ChildKind. I do site visits to go to different hospitals. I went to a small children's hospital in eastern Tennessee where they have set up a culture where everybody in the organization responds when a child is in pain. if you're a security guard, if you're a person delivering cafeteria trays, if you're cleaning the room, if you're Jeff Sperring. It doesn't matter who you are, you pay attention and do your part in acknowledging a child's in pain. And clearly, parents want to be empowered to advocate. You heard that from Anjali. They are frustrated when they see their child suffering. They know their child is suffering, yet they're not getting an adequate response from us. So, how do you change a culture? How do you go about doing this? How do we actually invoke the behavior change that we want to see? So the first issue is we need to make pain prevention and treatment a priority. By the way, those of you who know me, and you're about to hear it if you don't know me, I hate the term pain management. Pain is not something to be managed. It is something to be prevented and treated. Managing it implies that, oh yeah, we'll just, do what we can to impact it. No, we should be more focused than that. There needs to be messages from the top leadership down, which you are about to get in the next couple of months, because our most senior leaders have agreed to be the sponsors of this work and will be working with us on it. We've also had a Pain Champion Committee that has been around for a long time, and I would call that more the bottom-up, grassroots approach. That's people from different units with different jobs who show up every month to talk about how to improve things. One of the issues that's going to come into play is accountability. What happens if you don't behave in a way that shows compassion and respond when a child is in pain, as well as what happens if you do? How do we make that something that becomes more woven into the fabric of our culture? We want to facilitate advocacy. We want patients and parents to speak up. We want them to be empowered, and we want to meet them where they're at. Not be dismissive, not think that we know better, and be condescending. But we really want people to extend that kind of assistance. And we want faculty and staff to be receptive and to own this. So with that, as I kept pleading my cause here, I wound up being linked up with Timothy, who is in fact somebody whose job it is and whose expertise it is to look at cultures and invoke change in those cultures. So for the next quite a bit of the lecture will be his to talk about those kinds of processes. So thanks for your attention thus far.
Thank you, Gary. Good to be with you. Again, I'm Timothy McLaughlin, an OD change consultant in people operations and people solutions. I'm going to take a few minutes to talk to you about culture, culture change, and how do you change culture. So simply, what is culture? Culture is a few things. It is first, consistently demonstrated patterns in an organization or group. Secondly, it's the artifacts that reinforce beliefs and behaviors, such as policies, regulations, procedures, and protocols. For example, you guys take a Hippocratic Oath. That's part of the culture of being a physician. Do no harm. It is a bedrock for you. It's also the expectations that define an organization and its members. It is also written and unwritten guides that defines how things are done here. It's how we do things at Seattle Children's. Next one would be the standards to which we are held. And there are a lot of standards that are be held for physicians. Lastly, it is unspoken beliefs that we share with our team members as well. So, how do we change culture? The first thing we have to do is have a vision. And Gary has done an exceptional job in setting the table for why we need to address this in our institution. And the vision we're trying to establish is the future state we want to achieve. And to do that, you need a strategic roadmap for how to get there. That strategy is a systemic, step-by-step process that encompasses the why, the what, and the how to achieve those goals. Secondly, you need to be effective in terms of communications with that strategy and formulate how you're going to engage people to achieve that strategy. If you fail to do this effectively, your strategy will become much more difficult to implement, and most likely it will fail. Next, to implement your strategy, you need to monitor the progress through quality, or what we call pulse checks in our business, to address any issues before they become problematic, and or escalated. Additionally, it is good to obtain feedback to ensure alignment and assess the need for additional support and or clarification. It's essential that you ensure that everyone has the information that they need, that they have the tools that they need so they can make the changes you're asking them to change. And you also have to start to lead by example. What you want to do is have people model the behavior that we're asking them to model. If leaders don't model it, you're not going to do it as well. It's critical that happens. So in terms of simplistically, what is culture details? It's 4 interrelated elements, basically. It's explicit behaviors. It is artifacts such as logos, the colors of our institution, so on and so forth. You're wearing your white coat, you wear your stethoscope, so on and so forth. It is conscious norms, and it is implicit assumptions. And those things come into 2 buckets. They're observable, and they are unobservable. Say, for example, unobservable is stuff like internal beliefs. You might think that black people have a high pain tolerance. You might think that the needle injections don't hurt them as much. You might think a lot of things. But those are the things that guide our behaviors that are kind of unknown to us. They be keep internal. And we have to address those too if we're going to change our culture. So another thing, a good example would be, I heard once at one of my projects, is that someone thought that paid employees here are the real experts and better at their role, you know what I mean, as opposed to contractors, just by default. Just because they're full-time FTEs versus contractors. Now, the role of change management. Change management basically is a systemic approach to transition or transformation of an organization's goals, processes, or technologies. For our purposes, it's going to be thinking about this. We use ProSci, which is a construct we use for change management. There are 5 buckets to it. One is awareness, which is what we're doing today, which is addressing the nature of the change, why it is needed, and the risks of not changing, which are significant. A cautionary tale of not changing your behavior for your culture is Boeing, right? That's a good example, Boeing, one word. So, sorry, but it is. So then the desire piece of it, the addressing desire in WIFM means what is in it for me. So that enhances our decision to improve the outcomes. What are you getting out of this? Your patients are happy, the families are happier, you have more pride in your work as physicians. You leave these exchanges in a better place than you did before. So that should be enough. You took a Hippocratic oath, so okay, desire to be a better physician. The knowledge. So we need to build an understanding on how to change, learning of new skills. Gary and the folks are doing a lot of things coming down the road in a few months to help you support that learning and the change, how we need you to change, and the model what we want you to model. Not like you're going to tell you what to do and just leave you to your own devices. It's going to be a formal, structured process to get us where we want to be. The ability that promote actions that increase the likelihood to achieve the desired behavior change. And the last part of that is, which is important, is reinforcement. Because we need leaders to promote actions that guide explicit behaviors of teams. That's throughout the vertical from everyone within the organization. So that is important. Now, change framework. First, to be successful, we're going to require participation from both leaders and team members. Leaders are going to help us to address our implicit assumptions. Team members and leaders participate in the following: understanding why the changes in work practices are necessary and the risks of not changing, what changes will mean to existing norms and artifacts, the way we do our work day to day, and addressing the norms and artifacts that are likely to impede change. When you're used to doing something the same way all the time and someone asks you to do it differently, you might become annoyed. You might resist So if you have resistance, you have issues around what you're being asked to do, we want to uncover that and address that to get you back on the right path to say, okay, here's why we're doing it, here's what we need you to do, how can we help you do that? Lastly, we're going to make sure that we embed the new practices that influence explicit behaviors. So these are high touch. Will not be overly burdensome, not be, asking you to do a whole bunch of things, go to a bunch of trainings, a bunch of stuff you do not want to do. It will be targeted, high touch, and it's going to be effective. So we're going to use a three-step approach to do that. So we can have leaders provide with overviews and roles and talking points about what we want to have done. They're going to tackle the implicit assumptions about best practices. Step 2, the clinical team members are going to be trained on best practices and going to describe additional support needed to see if we need more artifacts, more norms, more this, more that. We're going to be following up with team members on embedding practices. And finally, the outcome is going to be embedded best practices become normalized. Now, this is where the rubber hits the road. What will you commit to do differently? So will you, for example, improve patient communications when assessing pain, simplify terminology, ensure tacit understanding? The young lady who gave the presentation earlier about her son, that was a prime example. So let's make a better effort of that. Clarity of patient perspectives, of patient concerns, and patient feedback. Are you really listening to what people are telling you? Taking greater ownership for patient care. That's a good one. Avoid thinking that someone else will take care of a situation where the need is obvious. As Gary mentioned earlier, if you walk by a room and a patient is in severe distress, and you may think, okay, someone will be there in 30 minutes to address that situation, you could have stopped, addressed the situation, which is the appropriate thing to do, as opposed to assuming someone else would get to it at another time. Be aware and consciously change a stereotype response. We all have that internal. We all have our own stereotypes. Me, everybody does. We're human beings. You have stereotypes. Challenge your thinking about stereotypes, what you think about a given situation or given based on race, based on anything, basically. Take a little extra time to learn about the background of your patients and families. Ask a few questions. Take a bit of time. Humanize it a little bit better. I know that everyone is hugely busy. You're on a lot of time constraints, but by the same token, if you could take a little bit more time to do that. Lastly, is increase opportunities to interact with someone different from yourself. I'm from the Washington, D.C. area, which is a hugely diverse place. I've been here for six and a half, 7 years. Seattle is not quite that, but DC, you're forced to. There's no way around it in terms of who's in that city. So I want you to think about that in terms of what you're going to be doing to do that. And so with that, I'm going to give it back to Gary. And thank you for your time. I really appreciate it.
So let's learn from other places. What's been tried, what hasn't worked, what do we not want to repeat? If you go way back into the 90s, which for some of you is ancient history, people have tried different strategies. Neil Schechter tried coming up with the ouchless place at his hospital in Connecticut, which really focused on needle pain, the idea that we would take away needle pain completely. Comfort Central was another term that came down the pike. This was where the organization put strategies into place to try to empower people in their environments and to generate collaboration so that pain became more visible, pain became something that people were paying attention to and working on. More recently, you might have heard about the Comfort Promise that was started at the University of Minnesota, which basically, again, focuses on needle pain. Why do people choose needle pain? Number one, it's everywhere in children's hospitals. And number two, the idea is that if you're paying attention to something as trivial as needle pain, for those of you who aren't able to see me on WebEx, I made air quotes when I said trivial about needle pain, because I think if you talk to many of our young patients, they do not see needle pain as trivial at all. Yet, if you try to make inroads there, then presumably people will pay attention to larger pain problems. These endeavors have met with various degrees of success. None of them have actually hit it out of the park. Childkind International is a group that was established in 2008. It has standards for multiple aspects of pain in a children's healthcare setting. You apply to Childkind to be certified and be recognized for outstanding work in pain medicine. Seattle Children's was the third hospital in the universe to get accredited. Parens, it had nothing to do with the fact that I was on the board of Childkind and sort of steering the boat with them. They're actually looking to come back and do a recertification here, but at least we have that accreditation. So what kinds of projects are we doing here? What's happening at Seattle Children's? What can you latch on to? So we have worked on needle pain in the past. We re-implemented some of those strategies for primary care at Odessa Brown. At this point, if you are a patient at Odessa Brown and you are due for immunizations or blood draws, you will be offered a package to address needle pain from the time you walk in the door, so that by the end of the visit, when it's time for the immunization, topical anesthetic will have been able to do its thing, and there will be some change in that regard. The feedback already has been quite positive. We are looking at a fairly substantial intervention for surgical pain. We are focused specifically on the inpatient surgical units. This will involve addressing pain at the clinic visit prior to surgery, day of surgery, once the patient goes to the floor, and giving consistent messages about the importance of treating pain and setting up expectations so that parents and patients can express their views and be heard, and strategies for escalation. We have champions working on this. The surgical pain project, that includes a big chunk from nursing, and very importantly, each surgical service has between 1 and 3 physician champions who have agreed to work on it. We have not yet begun to address issues with house staff, but that will be soon to arise. Patients and family members, as you have heard, have been involved from the get-go. We want them to be a focus of where we go from here. We want people to feel more educated about what their options are, and how to increase their impact. We are looking at the idea of treating pain as a preventable harm. I brought this up. Many of you may remember David Fisher. The David Fisher Award is still given for patient safety. I said to David Fisher years ago, so what if we took poorly treated pain and made that a preventable harm that needed to go through the whole evaluation process, et cetera, that any other preventable harm does? And he looked at me and said, if we did that, we would completely choke the system. And I said, that's my point. Paul Sherrick is interested in pursuing that line of reasoning. It will be in some modified form, but when people complain about their children's pain being so inadequately treated, we're not going to just say, okay, fine, business as usual. We are going to do a little bit more work around that. So what's the ask of you? The first one is so simple, it's ridiculous. You are a compassionate person. Be yourself. Just show the compassion that you feel to patients. Even if you feel like it's not the norm, even if you feel like you are taking time and doing things that people don't typically do, that's okay. We are shooting for a state where every person who works at Seattle Children's will react and show compassion when a child is in pain. Exactly what that looks like remains to be defined. I don't know what the appropriate thing is exactly for a security guard sitting at the front desk to do when a patient shows up and the child is obviously in pain. Obviously, they're not going to do a clinical assessment and start prescribing what should be done. On the other hand, they can say, wow, you look like you're really hurting. Let me do what I can to get you some assistance. Just by showing that kind of compassion sets a completely different tone. Timothy talked a bit about accountability. Wouldn't it be great if we made this a priority and it mattered? Like, wow, look what you just did for that patient and family. Great for you. Or you just had an opportunity to show your compassion and you dropped the ball. How could we do this better next time? We are really looking to empower patients and families. We want them to have an active voice here. What you heard from Anjali about feeling helpless and feeling like people aren't listening, and I know my child, why are you dismissing me? In my humble opinion, that is absolutely intolerable. We cannot have that kind of relationships with patients and families. So the way around that is to offer them the opportunity to be heard, educate them about what they don't know. Parents on the advisory committee were all about really wanting to understand more. They say things like, I don't know what I don't know. And if I don't know what's available, how can I ask for it? So clearly there's a plea from parents to be more educated. So this is a slogan we came up with when I first came here, which is now a very long time ago. Don't laugh. It's not fair, Suzanne. But the whole idea, and I think this, even though we came up with it a long time ago, it still holds, and that is we want to form a partnership around this. We want patients and families to feel like we are engaged with them. We have expertise and knowledge about evaluating and treating pain. They have expertise and knowledge about their children. Optimally, we want to work together. So here's an old Buddhist saying that I still love, and that is, pain is inevitable, but suffering is optional. I thank you so kindly for your attention. I want you to be charged up. I want you to walk out of this room feeling like I personally am going to make a difference in this culture. I am not going to leave it to somebody else. I want that to last for more than 2 weeks, because what the data would show is you sit in grand rounds, you learn new things, your practice may change for a period of about 10 to 14 days, and you're going to then revert back to the way you behaved prior to sitting in on grand rounds. So I know that already, and I'm challenging you to make this last more than 10 to 14 days.
Talk a little bit more about the work that's been done specifically in the emergency department with the sickle cell pathway. I think, like, from the perspective of an ER provider, hopefully we're making a little bit of a difference. For example, there's intranasal fentanyl now that our goal is to get some pain medicine into our patient within 10 minutes of arrival. Can you talk about that pathway and if you've seen any difference in our patients, in their comfort levels, or in their feedback so far?
I don't know the actual data that are being kept. I know there are, and that they are clearly showing improvement. I was part of that work when the consultants came to look at what goes on with sickle cell disease. You are correct, Suzanne, in that the emergency room was identified as a major stumbling block. Yeah. Tony Woodward has been very involved and very focused in really wanting to make some serious changes in this regard, and has invoked some good changes. When I heard what Anjali said about, yes, I've noticed a difference in the emergency department. It's not necessarily great or optimal yet, but it's clearly way, way better. Did I get that right, Anjali?
You did, yes.
Okay. So I think clearly we're headed in the right direction. I can tell you that the pain medicine team has been reasonably aggressive about treating sickle cell disease pain amongst the inpatients, including adding new wrinkles such as ketamine that had not been used for sickle cell disease previously. I still don't think it's necessarily a frontline drug that should be used with everybody, but I think there are innovations. So that was a great example where when the organization pays attention and puts effort and resources behind something, you can invoke serious change, and I would love to see that in other areas.
There's a question from Yuli Goost online, specifically for
sickle cell. Do we have enough data on what the best way to treat acute and chronic pain, and it's just a matter of implementation? Or is there also still a lack of data on the best and safest ways of accomplishing pain relief?
Sickle cell disease remains a challenge for a few major reasons. The first is it's a disease that affects every organ system, and in a way that we are still understanding more and more about. Strategies to treat acute vaso-occlusive pain are reasonable and are reasonably effective. When you get an overlay, being somebody that's been involved in some research on sickle cell pain for a long time, where you get into interesting issues is changes in the nervous system as pain becomes more recurrent or more chronic. And that's where you start to see a lot of sensitization to pain. That's where you start to see increased sensitivity to pain. And that is a much tougher road to understand and to treat. Heart, Lung, and Blood Institute, probably about 15 years ago, held a major meeting where they were beginning to recognize more and more that sickle cell pain does not automatically mean vaso-occlusive pain. There are a lot of other elements that come into play, a lot of other systems that kick in. It is a field that fortunately is getting increased attention. It's getting some increased funding for research. By no means are we where we want to be in treating it. But I will say that as pain science has infused more and more into collaboration with the hematology science, some inroads are being made. I am actually optimistic, which for me is striking. What I have seen over the past 35, 40 years in treating pain and sickle cell disease is radically better. Not still optimal, but radically better. Does that make sense, Anjali?
It does make sense, yes.
Oh, Anjali, do you have something else you want to say right now?
I did, thank you.
Go ahead.
I just wanted to touch real quick. I had this written previously, and I forgot to mention the importance of, so speaking from a person of color, explaining calmly the use of, and I'm calling them frenzied medications because of like the reports in the media. So when we talk about ketamine, we talk about fentanyl. I know that speaking with others in the community, those are what medications that there is more hesitance in using. So yes, I know the inhaled fentanyl has been offered to Nehemiah in the emergency room, and it is great. However, because I was a part of the pathway, I understood it, but his father didn't and had a lot of reservations because we hear fentanyl overdose, we hear these other things going on, and I know that there has been there's a lot of fear within the BIPOC community when it comes to certain treatments and things because there's been a history of like experimentation or using people of color to do trials and things like that. So I just want to share that you might get pushback as a clinician or as a provider. It's like I'm trying to help and offer, and then you're receiving pushback. And I would just say to be able to provide some clear information to give families ease when you're introducing medications like fentanyl or ketamine, because that can be alarming. I just wanted to add that piece.
A few more online questions and comments from Amy Trowbridge. Gary, this is wonderful. Thank you. And a huge thank you to Anjali for sharing your story. One question. You spoke many times about how untreated pain has become normal in so many of our psyches, even subconsciously. How can we change that as individuals on a day-to-day basis?
So it's a little bit enigmatic to me exactly what happens. But I think we've all experienced a degree where through our training and through working in these environments, we become a bit immune to crying. We become a bit immune to hearing expressions of suffering. And I understand why that's adaptive. Like if everybody's heart was wrenched every time we heard a child distressed in this environment, we couldn't come to work every day without wanting to do damage to ourselves. On the other hand, I think the pendulum has gone in a direction where it could be recentered a bit. So if the question is, what do I personally do? It would be consistent with what I said before, which is just be a human being. Just pause for a minute and acknowledge that there's a human being in your presence who is suffering. Maybe nothing more than that. And if you have the power to do more than that, then obviously do it, but.
Thank you. I think we have time for, oh, do you have another comment? Go
Yeah,
ahead.
just one last comment.
Please do.
Actually, feedback is an opportunity, personally and professionally, to grow, to learn, to improve. So try not to think of feedback as a negative. It is a positive thing to receive feedback.
Agreed. All right. Well, we are out of time. Thank you so much for everyone's participation, and especially Anjali for joining us online. Thank you, Dr. Walco, for doing this every year, and we will retain this for much longer than 2 weeks. So thanks, everyone, for being here. We'll see you next week.